Welcome to the season finale of Dr. G at the Heart of Healthcare Season 2. Happy World Hospice and Palliative Care Day. We have two wonderful people here, my hospice bestie, Dr. Lauren Templeton, and the legendary Judi Lund person, who was on the steps taking a picture at the Capitol on September 29th, 1982, for the Medicare Hospice Benefit in the United States. So that's what we're celebrating today. Welcome to the show.
Thank you so much, Dr. G.
Thanks for having me again. I'm so excited to have the two of you with me today. These are my favorite people who are just hospice advocates that we love what we do.
We're going to have so much fun today.
Oh my gosh. Last year I was able to talk to Barbara Carnes and I was totally like sweating. But now I'm sweating again. But I just thank you for being here. Last year, Dr. Templeton and I, we were at ALC, the NHPCO ALC, where you were honored at the National Hospice Foundation Gala for all of your work. And just want to say congrats to that again. I know you've shifted gears and pivoted. What have you been up to?
Well, it was really fun to be honored and also to make a few comments about what should be our North Star. So our North Star are patients and families. And for me personally, I was honored to care for my mother in the last days of her life when she was in hospice in Iowa. So I often tell the story, imagine the nurse who was doing the admission for my mother. And she doesn't know me, but I know her boss. And so we get, into it. Now, I'm a social worker by training. I am not a nurse. I'm not a doctor. I honor and love both of you for being doctors in this. And I could say maybe 3 nursey kind of words. So my mother had aspiration pneumonia secondary to COPD. So she was in the very late stages of her illness. And so at one point I said, what's her O2 sat? It's one of the 3 things I could say. And they said, oh, are you a nurse? No, I'm not a nurse. I just hang out with a lot of nurses. And so we go a little bit farther and I ask her another question and she says, oh, do you work in hospice? And I said, well, yes, I do. And so she goes on and asks a question, how big is your hospice? And I'm like, my sister is sitting there and she's like shaking her head. She doesn't know what to do. And so I said, well, I don't really have an average daily census in my hospice. I work for the National Hospice and Palliative Care Organization. And she pushes back in her chair from the table and she said, what? Well, what do you do for them? And I said, well, I'm the vice president of regulatory and compliance. And she's like, sweat is running down her face. And I said, and we'd already had a conversation about one of the meds she wanted to stop with my mom because, of course, she's on hospice now. And I said, no, we won't stop that med. We'll continue. We won't start a new course of medication. And I'm like, already I have all these mixed feelings of, okay, I know hospice really well. And, oh, no, this is my mom. And, oh, my goodness. Well, so that nurse leaves, the social worker is there as well. The nurse leaves, gets in the elevator, calls her boss, who I know, and said, do you know whose mom this is that we're caring for? So the social worker and I go back down to my mom's room. She's in the hospital. And Mary, the social worker, says to my mom, I think I had you, you taught at the high school, right? And mom says, yes. And she says, I think I had you for a class. And my mom taught home ec. And she says, oh, yes, Mary, I remember you. And Mary leaves, and mom leans over to me and she says, she was a terrible student. So it was just like all kinds of mush.
Full circle.
Right, full circle, all kinds of things. So,
Oh my goodness.
really, and so really, I think for me every day, now and all the time I've been in hospice, really focusing on patients and families. What can we do for them? How can we make sure that this is a good process, and people are there and available to help. So, long story, I'm sorry to say, but also really important.
But
Well,
can you imagine like taking
no.
care of her mom and being like, hey, yeah, you helped write this thing that we're doing. Like you helped make this whole Medicare hospice benefit happen. Like, let me make sure I do this election statement correctly.
Oh my gosh, I'm sweating right now. But no, we're gonna have a ton of stories today, so I appreciate that because that makes it personal, right? And that helps people understand hospice care is us bringing the healthcare to the home. And you have to, Lauren and I have touched on this, Dr. Templeton, about goals of care, about deprescribing or simplifying the med list. These are all real things that we've talked about in our 3 or 4 collaborations to try to help people understand how it works. So thank you for sharing that. So the theme of World Hospice Day is 10 years since the resolution. How are we doing? And that's a lot to unpack, right? I first want you guys to share maybe how you guys know each other, because I know last year I was in your class at ALC in Arkansas, and you guys were talking about GIP, and it was so awesome. But how do you guys meet? Because Dr. Templeton says you're her favorite person.
I mean, that's pretty much true.
Because it's so fun, right?
So this will be my 3rd leadership conference, and it was the first one. And I remember walking onto the floor of the exhibit hall, which is it's huge, huge. And this was in DC area the first time I went. And I saw her walking around with another member of the NHPCO. And I remember being like, look, there she is. Like, that's her. And so I was exhibiting with Weatherby Resources, who I do physician consulting for. And she came by the booth, and I remember being like concreted in my shoes, like they couldn't go forward. And so you were still recovering from your hip. And we're in a little scooter. And so I, being true Lauren Templeton fashion, was like, I'm talking to her. Like, I am not speaking to this woman.
Yeah.
And I knelt down and was like, I am your biggest fan. I just couldn't even say anything else. And she was like, I'm a fan of yours. I think I said, like, shut up. I was very starstruck, 100%.
Well,
and we've just been thick as thieves ever since.
Absolutely.
It's so good to have that, because I felt that way about you too, right? Weatherby Resources queen, our regulatory queen, who I always say keeps us out of jail. All hospice doctors.
Right.
Yeah. And so, we appreciate all the education you do with Weatherby, and that's just great work. So today, let's just go to the story. Let's tell the world about the hospice Medicare benefit, or Medicare Hospice Benefit in the United States. What was it like in 1982? And some people may know about the hospice care reform that we're having right now. So maybe we can touch on that and just kind of let people know what's going on. But what I want you to take from today, before we jump into that, is the title. A lot of folks think that when we sign on to hospice care, that's a loss of hope. And I want to first say, in all love and care, you can't spell hope without hospice. Hospice is not getting rid of your hope. Hospice is not letting go of hope. This is to you, family caregiver. This is to you, oncologist. I've heard that through a patient. They told me that their oncologist said they would never refer them to hospice because that would be giving up hope. Recently, I had a staff member say that a daughter didn't want to sign her quadriplegic mother up for hospice because that would make her lose the hope of walking again. We hear a lot of that going on, and we want to be sensitive to that. I don't want to dismiss it, but I just want to help you all see the beauty of hospice care, this health care at the end of life, and how it can be such a great benefit for your family and you. And so that's why we're here. So let me just let these two loose to talk about where we are and where we're going and where we've been.
Well,
Who's
so maybe
going
we
first?
should start with at the very beginning.
Yes.
So, and I've been working in hospice since 1980. And so one of the things that I started with, I was the state director in North Carolina, and there were 5 hospices at that time. And so one of my jobs was to drive around the state and talk to community groups about getting a hospice started in their community. So a lot of very passionate doctors and nurses and social workers and chaplains and lots of community leaders who said, my mother, my sister, my wife, my husband had a horrible death, and I don't want that for anyone. And that was a lot of the driver in the early days. Now, let's talk about the Medicare Hospice Benefit and when we began working on getting Medicare to pay for a benefit. So it was 1981, and a group got together in Washington, D.C., and the board chair for my organization was on the National Hospice Organization board, and he said, I don't need to go to this meeting. Why don't you go to this meeting in Washington? I was so young. I was so green. And so I went to the meeting, and I took the metro to the meeting place, and I walked in the room, and the people at the front of the room were whispering about, was I a spy? Who was I? Why was I there? Was I a spy? Was I trying to get some information on hospice or on lobbying or something? And so we cleared that up, but we had no internet, no email, no cell phones. We had snail mail, we had faxes, and we had the landline telephone. And so we started this group, this advocate group, to try and get the Congress to pass the benefit. And so there were 4 members of Congress who were really important. So John Hines from Pennsylvania, Senator Hines, and Senator Dole from Kansas. So a Republican and a Democrat on the Senate side. Then we had Bill Gradison from Ohio and Leon Panetta from California, also Republican and Democrat on the House side. But we went to them to talk about, well, how should we structure this, and they were very thoughtful. Our lawyers were involved, and we had a lot of very creative people at the very, very beginning of hospice, and trying to figure out what's the best thing for patients and families. So things like interdisciplinary, underline 5 times, interdisciplinary, not multidisciplinary, right. But we want the interdisciplinary team to be coordinating the care and working together. And it's not one discipline after another, it's everybody working together. So that's sort of one piece of it. Patient and family. This is not a benefit just for the patient. And in Medicare terms, that was like mind-blowing. We don't know whether we can do something that's for the patient and their family. Well, yes, that is a core principle. Symptom management, not just pain, but any symptoms that were causing that loved one to not have comfort at the end of life. And probably one of the things that is, maybe now it's a bit controversial, but volunteers. Volunteers from the start, that you would not have a hospice benefit without having volunteers involved, because part of the message is this is a community. We want volunteers to be a part of this as well, and that same volunteer requirement still remains today. So I think, as we started working on it, one of the jobs of all the people on the among the advocates was to call people in various states. So I lived in North Carolina, so I was assigned calling the southern part of the country, and I would call people that we knew, people that we'd heard in meetings, and we'd say, okay, can you reach out to such and such a member of Congress? Okay, can you reach out to, can you get some doctors in your community to help? And at the end of the day, a couple of things to keep in mind. This is the Reagan administration, a very big Republican administration. There had not been anything added to hospice added to Medicare, since for many years. And so all of a sudden, we have this group of renegades who are saying, well, we really need some help for patients and families, patients who are terminally ill, and we really need to do this. This is way too important. So and I was not part of the group that went to David Stockman, who was head of the Office of Management and Budget at the time, and we said the small group of the advocates that went to him said, here's what we want to do, and he said, oh no, everyone will want this. No, we can't do this. We have to figure out how to keep this from breaking the Medicare system because everyone will want it. And that's where we came up with the idea of that aggregate cap. So the cap in spending was a safeguard so that we were not going to break the system. We were not going to spend all the money that was available under Medicare. So, very thoughtful, very interesting, very interesting and deep conversations about what the benefit should look like. So the now famous picture of all the people on the Capitol steps is Leon Panetta standing at the bottom of the Capitol steps, and then 25, 30 of us standing there as well, right after it had passed the Congress and before the regulations were written. So we had passing the Congress in 1982, then CMS put out proposed and final rules at very beginnings, conditions of participation in 1983. Now, just a funny little aside is the person at what was then HCFA, the Healthcare Financing Administration, and is now CMS, was a man named Tom Hoyer. Tom was very, he worked, for Medicare. He was very thoughtful, and he was tasked with writing the regulations, which he wrote on his manual typewriter. And so part of my goal in life is to see if I don't want the original at all, but I would really love to see a copy of the original Medicare regulations written on a manual typewriter. So, it's part of it is that, and then part of it is how it actually passed in the Congress. So John Hines now has passed away, but was very, very, very instrumental on the Senate side. And that was when the Senate, you could walk around the Senate floor and get everybody to sign, yes, I'll support this legislation. So he walked around with his clipboard and said, you've got to sign on to this hospice legislation. Don't you think this is a great idea? And people signed on like crazy. So Leon Panetta, and he's certainly been involved in various things since then, but also doing that on the Senate side along with Bill Gradison. So, if we think about that time and we think about what we wanted at the very beginning and why this was so important. I had not had many deaths in my family at that time, but there were a lot of people who said, I am doing this because I never want another patient to go through what my mother went through, what my father went through, all of that. So very, very driven with the passion of that. And what I always hope for is that the passion, we will know enough about the past so that we don't lose the passion, or we can reignite the passion, so that we're like, this is why we do this work. And it is not the money, it is not the organization, it is not, establishing, however many new hospices there are, but it is because we care about what happens to patients and families as they near the end of life. Just full stop. That's really all we should think about at the end of the day. And then how do we get there from where we are then, where we are today, is another part of our conversation today.
Yeah, and so that is so beautifully stated. And so there's one stat that I often say, and I put it in the book, The Real Deal About Hospice, is only 27% of Americans know what hospice is and what it does. And as we are here today, trying to help people understand that there's no loss of hope, how do we get them to come to us? Because we created it because of the need, and we keep working because we know that they need it. How can we dispel that barrier of hope being lost, Dr. Templeton? Maybe you want to touch on that before we continue the timeline of the hospice in America.
Yeah, I love, Judi, when you're talking about interdisciplinary group. And for the most part, the healthcare industry hasn't taken on that model, except for, a few isolated systems. And the ones who have really shown these amazing outcomes when you really connect someone into the healthcare system. And so I think it starts with communication, and that's what the interdisciplinary group does, right? We communicate about meeting the different aspects of the needs of our patients. And so how to keep hope alive? Look, unfortunately, this will always happen. And so the way I explain it is, you're facing this very difficult time. You can face it with a support team that will help you with all of these different types of the care that we provide, or you can face it alone and without us. And so the hope there for me is that hard times are hard times, but you don't have to do them alone. And you have this group of people that are there to support you and your loved one. And so I think that when we say things like, oh, you give up hope when you face hospice, what I say is that you give up resources when you don't choose hospice. I mean, this is coming. And I hear a lot of people speak to the fact of like, oh, I want aggressive care. And I say, yeah, me too. I want aggressive hospice care. I want aggressive palliation. I want to use the medications that we need to use. I want to be seen by a nurse every day in the last days of my life. I want a physician visit. I want the physician at the head of the decision-making for me. And it all comes down to communicating that hard things are going to happen, but we can do it together with the patient at the core of our decision-making. And that's what I want to hold on to, is that interdisciplinary group.
Fantastic. Judi, how do you think we can create better communication with, enthusiastic hospice physicians like, me and Dr. Templeton, with our specialists, our hospitalists, our cardiologists, our pulmonologists, nephrologists, the surgeons, so that there's a better transition here? Someone used the term about people crashing into hospice. That's not my term. Someone said it, but that's often what we see, and we do the best that we can so that they end well. How can we improve that communication and bridge with the healthcare system?
Well, and I know you and Lauren are experts at making sure that you've got communication going. And, in some ways, I think we are thinking about our specialist physician partners as another member of the team. So if we can describe how any hospice physician can take the load off of some of the things that specialist physician is facing, let's work on this together. Let's see if there are some things that we can do that will really, really help. I think all of that is a part of what we're really trying to do. It's all communication. It's all, how can we be the best support to you? How can we take the load off of your shoulders and share it with you?
Yeah. Anything on that, Dr. Templeton?
Yeah, I really like when you said, how do we take the load off your shoulders? I think the best point that I can make to other physicians is, again, saying, hey, that difficult conversation is coming, with your endorsement and your opinion. Can I help you talk to them about this? And so, you can call me when they're in your office and we can come visit them there and talk about the hospice benefit. And they may not choose hospice that day, but wouldn't you rather your patient be informed? And wouldn't you rather let them know about all their options rather than, Friday at midnight in the emergency room? This is that crashing into hospice experience. And so when you partner with them, I feel that there's more success. And part of partnering with specialists is taking on the load of what our expertise is. Let them be experts in their area and then assist them when they're transitioning into our area.
Yeah, that's good. And this is live streaming everywhere. So I hope everyone is just taking notes. We will be able to, post it and you'll be able to listen to it again. But I want to define the interdisciplinary team for our new listeners because they may not have watched the other episodes. They may not have seen all the things that we touched on previously. So when you come on to hospice care, you have hospice physicians, and leading the interdisciplinary team, but we're a team, right? The next person that I like to highlight is the hospice nurse, the RN case manager, the registered nurse. I call them the quarterback because they are the ones, throwing that ball. Then we have our social workers. Then we have a chaplain for bereavement and spiritual care. It doesn't have to be a chaplain, it can be a bereavement counselor. And then we have hospice aides or home health aide. They're a non-core member, but super essential. And they usually know the patient and families the most. And so we have those. And some of our larger corporate hospice agencies here, they may have music therapy, all these respiratory therapists on staff and things of that nature. So that goes to the point of listeners, choose the best hospice agency. We have an episode on navigating hospice compare on the Medicare website. So whenever you're at that stage, you want to go into, that website, put your zip code in there and look for 3-star and above agencies in your area to help your family during that time. But we have a ton of episodes that you can go back to. Today, we just wanted to hit the high points, right?
Yeah, I think in that public selection of hospice too is look at, you talked about the nurse quarterback, look at that hospice that shows up in those last days of life. And so we call that hospice visits in the last days of life, or HVLDL, and that's a publicly reported measure. And, it's not ever going to be 100%, and it shouldn't, because we don't actually predict the timing of death, but we're really good at guessing at it and supporting our team. And when I think about that 3-star and above, I also think of who's showing up for you in those last days. And that's you want the members of the interdisciplinary group. And so that HVLDL quality measure for us as hospice, we know that as a quality measure. For consumers, it's who's going to be there for you in the last days. And so I think that's a good measure of a great hospice that consumers can take away, is that you're going to have the support that we said hospice was all about, the interdisciplinary group.
So I wanted to add to that and also talk about the so very important piece of this, which is the individualized plan of care. So you've got this wonderful team, and then you've got any of us as a patient or any of our loved ones as a patient, and you go, what do you want? What do you want if you're the patient? What are your goals of care? And I know you've had a lot of conversations about goals of care before now, but also we have the opportunity to create address the most important goals that patient might have. And honestly, how incredible is that? For my own mother, she really wanted that music therapist to come and sing to her. And what did they sing? Songs from the 40s. And my mother, who was almost comatose at that point, could sing along. It was really, really something. So that's that's who we are, that's who we are. One of my neighbors, when I was very young in hospice, said he wanted to have a lawyer come because he wanted to change his will. Well, the lawyer came to his house, was a hospice volunteer lawyer, and helped him kind of get his affairs in order. So it's not necessarily a care, it's not necessarily physical care, but it is taking care of whatever matters to that patient and their family. So also just, how awesome is that? That a patient can say, I really want to go, I'm really worried about this or that. And the hospice listens to that.
Yeah.
When you crash into hospice, you don't get those amazing stories like we do. I think of my favorite experience was to arrange a wedding, and just all the feels about that. It was incredible. We had the best man was the nurse. She was behind the patient, and she had pre-filled syringes in her pocket, and she helped medicate him when he became too short of breath saying the vows. And I was in the room there. I can't imagine a better interdisciplinary group and collaboration. It was absolutely incredible. And so when we talk about taking away hope, that's the hope that's taken from me, is that we can create this magic at the end of life. We can create people who can sing along to their favorite songs while they're dying. We are so good at that, but it really takes consumers to understand that that's what our goals of care are. That's what we're talking about. And the healthcare industry to get that's what we dive into as a hospice team. We dive into, I'm really worried that you might not make it until Christmas, and it's today, September 13th. So how about we schedule Christmas for October 15th and let's make it happen. And to me, that's hope. That's hope to have these amazing experiences with your family and your loved ones. And so it just, it's the magic of hospice. Absolutely.
Yeah. Maybe we can touch on too, the NHPCO facts and figures. 2024 was just released. I haven't had a chance to review it, but 2023 showed how the new median length of stay on hospice had gone from 18 to 17 days. And it's like half of the beneficiaries, what is it? Millions.
With
that were above and
million,
half below. Right. How do we get them to come sooner? Come on. What is your advice, Judi?
Well, it's interesting because it's been 17 or 18 days since the year 2000. So for 24 years now, we just have not seen that median length of stay move. Now, there's a little bit more spread with the longer length of stay patients, but I think in some ways it's patients have to be ready. In some ways, physicians have to be ready. And, I think there's nothing that you could sort of pin on as the only reason for that short length of stay. And sometimes it just is what it is. So I don't know, Lauren, maybe you have some other thoughts on it.
This is where I say the best marketing is to be the best hospice, and you'll change that within your community when you're a good hospice provider. And so we need good hospices to be providing good care, in my opinion, to budge that locally, so that, when you are taking care of your mom and your mom has excellent care, and then something happens with your aunt, you have this resource that you've already seen that's not scary, that's excellent. And maybe we can make that change with really good hospices across the country. And I know Judi and I that's one of our major works professionally is enhancing these really good hospices to continue to provide excellent care.
Yeah. Well, you mentioned in the beginning, one of the four legislators was California, and California love. I have to always give a shout out to my state, but I know we get a bad rap for a lot of the fraud and things we're seeing in hospice. And we want to celebrate today, but we don't want to shy away from some of the realities and concerns that we have, because we don't want this benefit to be unavailable for people who need it because of those who may be involved in fraud, waste, and abuse. So we are aware of the Hospice Care Act. And so I just want to hear from you first, Judi, and then Dr. Templeton. What was it like when you read that? We kind of talked about it a little bit while we were at Hospice Action Week, and I saw you at Elevate, and I heard someone cried when they read it. I don't know if that was you or Sheila, but just talk to us about the Hospice Care Act and what hospice agencies can expect, because I know they're challenged with long let them stay. There's a lot of challenges, but we do the best we can. So let's just talk about reform.
Sure. Well, I think what we're looking at now is trying to make sure that all that time ago, what the intention of the hospice benefit was at the time is carried forward to today. And so some of the components of the Hospice Care Act are things that are program integrity related. So it's not introduced as a bill yet. It's still in draft and should be coming out as a draft piece of legislation sometime this fall. But I think there are two parts, program integrity related things, tightening up some of the requirements from CMS to hospice providers, and then also starting to look at some changes to the payment system and paying when you actually provide a visit, paying for certain things differently, encouraging hospices to provide the more expensive treatments like palliative radiation and chemotherapy or dialysis or blood transfusions, which should be part of hospice. So, it's going to be, I think, a journey, but certainly there's a lot of discussion going on already about kind of what the component parts are.
Mm-hmm. Yeah, I think, Judi, you as a mentor to me have opened my eyes to there may be really good things that have negative consequences and negative things that have really good consequences. And so, I'm cautious in that manner to see exactly how this is going to come through. But some of it I was excited by, the respite type of introduction. And I thought of this as parts of it upholding the origin of the Medicare Hospice Benefit. But we'll have to see that. We'll have to see what happens, just like everything else.
Right. So I will share with you one of my kind of mantras, especially as we've been talking about some of the reforms that Dr. G, you and I have seen a lot of in California, but is you are not going to do this to the benefit I helped create. You are not going to do this.
Woo!
So
period.
Exactly.
Let's put that on a coffee mug and then put JLP underneath.
Exactly.
Did you hear that, world?
Yeah. Mm-hmm. So I think that's a piece of it. Because we have to honor our past, we have to honor the history that brought us to this place. And it's like, and then the other thing that I say pretty often to anybody who is really digging into some of the fraud related issues. How dare you? How dare you do that? How dare you not provide a single day of care and get paid for it? So no. And I think, Lauren, maybe that is the bad things that have possible good outcomes at the end, is that we will get some of this out of here and really start to make sure that whoever is in hospice as a provider meets the requirements.
Mm-hmm.
Drop the mic on that. You will not do that.
To my benefit.
We're going to go around now. We're going to say, and we're with you.
Right.
Yeah. Well, I think we hit on everything. Like I said, we just wanted to highlight and celebrate World Hospice Day with our legendary Judi and our in the trenches Dr. Templeton with Weatherby, and just celebrate the benefit and educate you all on it. We'll have some links to prior episodes so you can learn about goals of care and things of that nature that we've talked about previously, about finding the best hospice agency. Maybe we'll find that picture on the stairs, 1982. But we're just so grateful to be able to work in this field. It's so sacred. It's so special. Yeah. And we get to make a difference. And I just want to say happy World Hospice and Palliative Care Day from Mourning Dove Medical, but we'll go around and let you two have the final words here.
Yeah, I love that. I love the magic of hospice, and it definitely, to me, is about hope. And I'm grateful to talk about something that I believe in, and that clearly we're going to work to preserve, providing for these patients that deserve to have a beautiful end. Absolutely. Absolutely.
Yeah, absolutely. And I think for all of us to think about our loved ones, and if a bad experience drove us to this place, to make sure that the ending for a lot of other patients is better, then that's a terrific outcome for that. But also to say, for all of us, patients and families are our North Star, and so important to keep that in the front of our minds at all times.
Amen. I end with that. So thank you for joining us on this season 2 finale, The Hope of Hospice Care. If you have any questions or follow-up, we're all reachable on LinkedIn. I'm going to put a link to Judi's website in the show notes. And as you know, Weatherby's everywhere. You can always reach out to Dr. Templeton there. But we are so grateful to bring this show to you. And we just want to wish the world happy World Hospice and Palliative Care Day. Wait a minute, I forgot. This is a live stream, so I can keep going. You mentioned that one of these World Hospice Days, you interviewed who, Judi? You said that, and I almost fainted.
Years ago, another colleague and I interviewed Dame Cicely Saunders, who was the founder of the modern hospice movement and was a physician, nurse, and social worker in
the whole team
at St. Christopher's. Yeah, she was the whole interdisciplinary team rolled up into one, right?
Yep.
How was that to meet her? We're 1 degree of separation from her, Dr. Templeton. Can you believe that?
Right.
No.
It's amazing, isn't it? Right.
What was it like to meet her?
It was so, I hate to say this, it was so normal. It was just like,
of course it was.
So sitting there talking to her, she, talked about hospice in the UK, and what things were really important to her. But it was very, it was really the honor of a lifetime for me. So it's just really incredible.
Well, it's been an honor of a lifetime for me in my baby hospice career to have you here and to collaborate again with Dr. Templeton. I appreciate you all. Thank you for everything that I learned from you, and best way to end on that story. So peace, everyone.